Am I audible for everyone?
Yeah.
Okay, all right.
Yes.
Okay. Good evening, everyone, and thank you for joining in. I'm just letting even Dr. Krishnasai Reddy know that we are going to record this session and upload it on YouTube for other people to learn from the case presentation. And
Yes.
I am delighted to introduce Dr. Krishnasai Reddy, who is a distinguished consultant medical geneticist and a genetic counselor at Progenic Genomic Solution. Dr. Reddy is a top graduate from Parole University, specializing in genetic disorders and hereditary cancer syndrome. His accolades include the Best Poster Presentation Award at the 8th International BGCI Conference and the Best Innovation Award in Green Chemistry. An accomplished researcher and educator, Dr. Reddy has also authorized publications and delivered numerous guest lectures. His work in and personalized medicine significantly advances patient care and medical research. We at GCJournalClub welcome Dr. Reddy and offer the floor for his valuable case presentation. Thank you for joining us, sir, and presenting your case study.
Thank you. Thank you for the introduction. My
Glad-
pleasure to coming here. Yeah. Shall I start the presentation now?
For sure, sir.
Yeah. Let me know if my screen is visible or not.
The screen is visible,
It's
sir.
visible.
Okay. Yes. Sorry for the back-to-back sessions. I can't able to manage it. But anyhow, thank you for inviting, and we'll make this session as a beautiful discussion. I just want to present this more as a discussion than a case. That's why I'm here to, I need your perspectives and your collective kind of suggestions over this case because it's still going on. We're actually in between of this case. So let's discuss further. Yeah, we'll focus on undiagnosed genetic conditions and their effects on relationship dynamics. We know that every parent, every as being a human need a good life, like it's a kind of a a dignity of life. But whenever we can connect with the medical scenarios, especially for the genetic conditions and disorders, we can't able to let it go because we can't predict what might be happen. Even though we have an advanced technology such as next generation sequencing, or we have a the precise micro deletions with the micro arrays, but we can't able to detect some conditions in some scenarios. So for that cases, for that undiagnosed cases, so what the perspectives? When we are in the shoes of the patients, what the conditions? They can't able to do anything because they can invest money, but they can't able to rule what the actual disease or the problem is. So then the complications are completely different. So that is what we can able to discuss now. I'm going to present a case that we can have a discussion. Wait a moment. Acha, wait. Got it. The slide turner, right? Can somebody please
Yes,
let
sir.
me know?
Yes.
Yes. Okay, right. Yeah. Table of contents here. We'll discuss about the case scenario, the condition of the children, and we'll discuss what are the social pressures, dilemma, and psychological stress of the parents. and unknown diagnosis. As I mentioned earlier, it's an unknown as of now, but I can't able to say that is it known or unknown, because you can discuss. Yeah, the genetic counseling perspective for such conditions and future plannings. So what to do and what the next step to be taken. Yeah. See, the- yeah. Parents of children born with disorders, this is a generalized phenomenon. Generalized, the statistical data from India and to the world population data. Parents of children born with disorders often face significant stress, probably, which can strain familial relationships and increase the risk of divorce. Studies indicate that the divorce rate among parents of children with developmental disabilities or genetic disorders is generally higher than the general population. So, whenever you are seeing the statistical data of a group of people, a study is saying that they are taken a group of population. The populational studies indicated that the divorce rate was higher than in a general population with a developed disability or a genetic disordered babies. For instance, a study found that parents of children with ADHD, attention deficit hyperactivity disorder, have a divorce rate nearly twice as high, but that is 22.7%, as those without 12.6%. Similar trends are observed with other disabilities, such as autism, where parents face a 23.5% divorce rate compared to 13.8% in general population. I'm not intentionally mean to indicate the concept of divorce in this case, but what I mean to say, because this particular case, I mean, this particular, the case, what's going on from more than 8 to 9 months with me, I'm getting to know that a lot of scenarios has been changing from day to day, because there is no point of getting diagnosed by by any test, and there is no one is giving assurance to the family, and it leads to a lot of complications and changes. So that actually tend me to make the case perspective from a divorce situations. Yeah, it's just because of social pressure and stigma. Social pressure is completely in many cultures. They are unfairly blamed for their children's condition, which can lead to social isolation, emotional distress, and marital strain. Definitely, because the society, the circle, and even a disabled child can't able to get admission in the schools, and everything is traumatic, is not like a normal thing. No? And the stigma is not only exacerbates the stress of managing their children's health needs, but also their mental well-being and relationship within the family and community. So definitely, raising a child with a disability or having a child in the shoes of parents, it's a different scenario. So let's discuss the case here. A 2 years old boy, if it's a patient medical history, 2 years old boy, they got a clinical indications whenever the boy has been soon after the birth. The gynecologist has indicated with the clinical indications such as delayed cry, slight facial dysmorphism, micrognathia, open mouth, clenched fists, Schwartz sample like faces, like the structure has been abnormal, and feeding difficulty, brachycardia, asphyxia, neonatal seizures, and infantile spasm. So these are the things which the gynecologist initially written in the data, like medical records. That is what we get. So we dig into the deep of the history of the particular boy. The parents are non-consanguineous couple; they are not consanguinely married, and soon after the marriage, they conceived naturally after 3 months. All antenatal scans were normal, so there is no indications of any abnormality or something. And it's a full-term baby. It's not preterm and normal vaginal delivery. It's NVD. But IUGR indicated. So I'm not sure because I don't have enough records from the parent. They are indicated IUGR. The gynecologist has indicated IUGR and 15 days hospitalization with ventilation support. This is what an initial primary clinical evidence what we get from the parent. But what I want to mention, no significant family history. So it's one of the finest thing to say. So there is no significant family history, and it's a first child. The T4 was normal. That is what the point is. Point I want to mention here. The T4 was normal because we have seen that a slight facial dysmorphism is there. Actually, I want to post a photo, and I have a couple of videos of the baby, but the parent is not agreed. That is why I can't able to. So the slight facial dysmorphism is there, and microgathia, the jaw, it's been very small, and it seems like abnormal. And example like faces, Schwartz example, the shoulders has been scoused down and the spine has been just slightly bended, and brachycardia, aspaxia, and they have indicated cord around the neck while delivery. So these are the initial indications, but even though the already T4 got normal, so that's what made me surprised. And the gynecologist indicated the cord around neck and infantile spasms, and the father indicated that it's a rural village where no NICU facility was there, and external O2 support was there, so they have rushed to the hospital. That is what they mentioned. So it takes a lot of time, mean 2 to 3 hours of time. They have got a good hospital to join in and admitted in NICU, neonatal ICU. So this is what happened of the birth when the birth of the baby. Oh, I'm sorry. Yeah. So, diagnostic indications. What are the diagnostic indications, right? Okay. So, what are the diagnostic indications? Soon after that, the gynecologist or the pediatrist who come across with the baby, they started to asking to go with MRI and neurosonogram, and along with whole exome sequencing. The MRI indicated T1 hyperintensivity with T2 hyperintensivity and mild atrophy of bilateral thalami, which actually cause uh, the shape of the brain has been modified, and it's not completely modified, but it's mild atrophy, and it usually can cause, if it continues, if the brain doesn't grow further, then it causes mental disability, cognitive impairment. So that is what MRI has been indicated. And neurosonogram indicated HIE23, which also indicated the peaks. Neurosonogram is nothing but with an ultrasonography, they used to scan the brain. So they can see whether any abnormalities or if any fluctuations has been indicated through the neurosonogram. Whenever the baby moves, any fluctuations. So the neurosonogram indicated HIE23, and whole exome sequencing. We got a report of whole exome sequencing with no patho or likely patho, but the whole exome sequencing report indicated with a gene called SCN3A of this particular variant of autosomal dominant condition, but it is a variant of uncertain significance, Bose variant. The disease indicated with the disease associated with the gene is developmental and epileptic encephalopathy 62. So even I'm not very clear about that particular. I know encephalopathy, epileptic encephalopathy, but what this particular SCN3A, which is associated with seizures and developmental delay, and the baby has structural abnormalities, and I don't know, it might be a syndromic features we can't able to assess. But whole exome sequencing has figured out with SCN3A mutation. And the zygosity is heterozygosity, and the correlation is, yes, it's matching with the phenotype. So let's dive into the developmental and epileptic encephalopathy 62. It has a severe, it is a severe neurologic disorder characterized by the onset of various types of refractory seizures in the first week or months of the life. Yes, the baby got seizures soon after the birth, like soon after 15 hours of the birth. He got first episode of seizures, then it will lead to continue. Until now, it has been progressed. So the baby currently is 2 years old now, 2.3, I think. So yes, he currently has seizures and in a management protocol and having a treatment of symptomatic treatment. The affected individuals have severe to profound developmental delay with hypotonia and impaired motor and cognitive development, as I mentioned. Additional features may include spasticity, microcephaly, and brain imaging abnormalities. With respect to SCN3A is a gene that encodes the sodium channel protein type 3 subunit alpha. This protein plays a crucial role in generation and progression of action of potentials in neuron, which are essential for normal brain function. So we know that we have a lot of neurotransmitters and enzymes which are associated with the protein of action with a cluster of neurological genes. That is why we can't able to figure out a particular gene, because whenever you compare with the neurological cases with the other cases, you can't able to distinguish, because the neurological cases are very hard to crack, and we got a lot of VUS when compared to the normal cases. So this particular variations in SCN3A gene can lead to a range of neurological conditions, including epilepsy, developmental and epileptic encephalopathy, DE, and other neurodevelopmental disorders. So yes, the thing is, because till that phase, patient not contacted us. So we are not yet entered, but what I'm saying, I get the details from the patient. So they asked for the Sanger confirmation was suggested for the baby and parents, because soon after that we have confirmed with the whole exome sequencing, they need to get clarified with the particular baby, particular variant of the gene in the baby too, and the baby and parents too. Yeah. So yes, the Sanger sequencing report indicates that that particular gene variant is present in the father and absent in the mother. So yes, if it is an autosomal dominant condition and the same variant is present in the father, but he is asymptomatic, right? He is asymptomatic, but the results showing that the father has present that variant and the mother is absent for that variant. So yeah, it's now the door was opened. It's quite a tricky question to explain and counsel the patient. If the father has the same variant with asymptomatic, then is that the variant is correct in the baby, or that might be not the one which is causing that particular condition? So that is what the questions are. So yes, but soon after that, I've seen the counseling protocol and counseling summary of the particular condition of the parents and the baby. The counselors are clearly indicated that yes, sir, your gene, your variant, because both mother and father has been sharing 50-50%, as that you have shared the particular variant to the child. So they're I don't know how the counseling process has been gone, but they indicated that you are the responsible one for your children's situation, your children's condition. So that actually made them panic, and it's open a door of quarreling between wife and husband, between the couples, of yes, you are the reason for the problem with the child. So father is got blamed due to the scenarios and all. Yes. So that is why whenever we are counseling to the patient, our every word should be watched. Every word should be watched, because it is a BUS variant. You don't have a clarity, because as being a counselor or a clinical geneticist or a superior MD, whatever it might be, it is a VUS variant, BOS variant. We don't have a clinical evidence that this is a particular variant which has particular condition associated with the baby's phenotype. So we don't have any clarity. Then how can, see, that is why whenever we are assessing a report, we have to be very clear, and we have to be very conscious, and we have to be revised prior to the counseling session. How can we deliver this report? This particular event made a vibrant waves in his family and his total life. So soon after that, there is nothing to do, because the neurologist can't able to do anything, because it's just encephalopathy, and it doesn't have any targeted regimens of the drug indications. So he went through asymptomatic treatment. Bas, kuch bhi nahi hai. We can't do anything. So then they have gone with the went to second pregnancy because nothing to do, no. So what else they can do? They went to the second pregnancy. And the tricky one is it's a Vous variant, VUS variant. We can't able to, according to the guidelines. If it is a VUS variant, because you can't able to say that variant is responsible, how can you say if the same variant is present in the next child, whether you can say you can abort the baby because the father is asymptomatic for the particular variant? How can? So that is what the question is. So okay, they went to the second. So with all the chaos and unpredicted, unsolved case, they went to the second pregnancy. That is what the biggest mistake he done. Yes, the previous child was treated symptomatically, showing no improvement till date. Couples planned for the second child because they don't have any. They left with no choice. Yes, they approached me. I think it's on 22nd week of their, I think 22nd or 23rd week of her gestation. I mean, she was pregnant, and that session, gone through with collected all the data and all the information of the previous child, all the information of the previous genetic counseling report, summary, and everything. And for the second baby, the NT scan was normal. NIPT done with micro deletions and duplications. It's an advanced NIPT, and that too normal. No chromosomal abnormalities were figured out, and the micro deletions for the conditions, 5 top conditions: Prader-Willi syndrome and Cry-do-chat. So everything was normal. They went to that. Everything was normal, and TIFA at 80, no, they've done at 20th week. The TIFO was indicated with a situs inversion. Situs inversion is nothing but, all the body parts are just shuffled, jumbled to the positions. That is called situs inversion. You can see dextrocardia, where we have a slightly left side of the body, but it's right side of the body. But the gynecologist was very stubborn and strong because she had delivered a lot of babies with situs inversion. They are living the happy life without any complications. They don't have any conditions, and so that's might be a wrong decision. But gynecologist has been very confident that don't abort the baby. Please go ahead. So as being anxious parents and want a beautiful child, so why, and a healthier child, why can't they believe the gynecologist's suggestions, and they tend to continue the pregnancy. Now the discussion. While our conversation, the parent raised a bunch of questions. The question number 1: how can I'm asymptomatic but my child does? Yes, as you are saying, the same variant was present in me and my child. How can I be asymptomatic? That is what the first question he asked. The second one: if I am asymptomatic, because the good thing was he is an ophthalmologist. He is an ophthalmologist from a medical background. He know a lot of things, a lot of stuff in genetics. That is what he raised a lot of questions. If I am asymptomatic, then that variant is not the causing variant. Is it right or not? That he imposed to me. Then he asked it. You're saying that is an autosomal dominant condition, and I am having the variant. Can I develop a neurological problems in near life? So that is what the question. Yes, so everything is to be. It's not like a foolish question, or we can't able to trash it. It's definitely a worthy question, and we have to answer if we can able to. Next question is: we don't have any family history. We are healthy, but why? The question is why, and he is from a medical background, and the woman, the parent, the mother was completely get through the folic acid and regular checkups and everything. Antenatal scans were normal and everything was good. But why? The question is, but why? And what if my next baby with the same problem again? That is what the question is. Okay. I opened up this question to the discussions. I'll move. So, second pregnancy. For the second pregnancy, it's a preterm baby. Unfortunately, the liquor was very, very low. So the gynecologist bring an alarm and raised an immediate emergency to LSCS, lowest section, cesarean section, because it's completely low, liquor low. The complications of low liquor, low amniotic fluid, that's oligohydramnios, it lead to severe psychological problems, severe psychological impairment. I mean, not psychological. I'm sorry. Um, Psychiatric implement, like the baby can't able to memorize, and definitely the baby have neurological issues and cognitive impairment, behavioral, because of many. We have seen a lot of autistic childs is one of the reason behind them is you know cord around neck and oligohydramnios is one of the basic factor. And it's a girl child, did not carried after birth, cried, I'm sorry, did not cried after birth, and she also had cord around neck. That is what the indication was. NSU admission has been done, but fortunately no seizures. But the problem is the pediatric surgeon got to check the baby. The baby intestine was abnormal, and the colon region was completely closed, and it doesn't open to the rectum. And he suggested for the surgery. Yes, a major surgery went through ileostomy surgery because the baby can't able to pass the stools further. So yes, now the official condition has been more complicated here, because we have done with the chromosomal abnormalities, we have done with TIFA and regular checkups and antenatal scans, and even for the micro deletions. We are very clear, we are very prepared for this baby, but we can't able to assess what's going on. We can't able to do that particular host variant within the baby because we can't able to see, and it's against to the guidelines too. So what to do? And I'm also questioned here because I'm left with no clue what to do. Yes, but he's asking why, and his family complications has been much more tightened. Yes, now the complications has rised up, and the society complications was completely, definitely they asked it, they blamed the father. Yes, because of you, every child is born has been with the complications, with the problem. And they were charged up more than 5 lakhs for the surgery and the delivery, 5-6 lakhs for the baby. But the baby was not normal, and she also having the shortness of breath and can't able, the second child which can't able to breathe, and in ventilation support, I think I mentioned. No, she has also had in ventilator support for next 7 days, and now she is able to breathe normally, and the surgery went good. But the gynecologist and pediatric surgeons saying that we have to wait for 3 to 4 months. If the seizures are not arrived and no complication has been arrived, then we can able to say anything. So now the problem is really critical. The father has blamed for this because the previous child has the same variant, that unknown variant, because we can't able to say that particular variant is responsible. That unknown variant is carried by the father. So that is what the question is. Pressure from the family and relatives, because you have some problem within you, better. You have to check. You can't able to, you are not fit for the family man, and you are a lot of blaming pressures has been going on in society. Yeah, and yes, of course, but unfortunately, some partners have been cooperative, but some partners have been not cooperative, and in this particular situations we can't able to judge the partner too. And she asked for divorce, disturbance within the marital status, because with the problematic children, and the person who can't able to deliver a child, I mean, person is responsible for a problematic children, how can I be cope up with till lifelong the conditions are. So that is what she asked for the divorce. The previous child with no improvement, yeah, it's 2 years over, there is no improvement, and the clinician is saying he can't able to, provide. I mean, prolong the life. The prognosis was very worse than they imagined. They asked for at least 5 years, but he is saying no, 3 to 4 years. So it's the complications were very high. So this is what the cluster, the bunch of questions and the pressures of the father. So we I mean, this last step, yeah, we counseled the patient. I mean, the both couple, we asked for a lot of sessions. We did. We counseled and convinced for couple at last, because they are literally want to being apart. So, but just because of the problematic children and the concept of father carrying the variant. I mean, father having the same variant, but he is asymptomatic. So we asked for go for couple carrier screening along with whole exome sequencing for the newborn child, and we acquiring the VCF data, the data of whole exome sequencing of previous child, so to get analysis a comprehensive indication. So this is what a structure of case and where we are at and what we have to. And yes, these are the questions what we are open for the discussion. And I hope, yeah, let me know your suggestions. And yes, Kruti is raised the hand. Yeah.
So one question I have about the clinical indication. Are the seizures refractory?
Yes.
Okay. So one way to explain the first question that you put up, that why is the child affected and why the father is asymptomatic, is because of the penetrance that is
Yes.
known in autosomal dominant conditions. And from what I can see on gene reviews, this the penetrance for this disorder is not particularly well known. And
Yes.
again,
Yes.
what the variant you identified as a VUS. So of course, we can't really say that it's a causative variant for sure. The best, of course, the next step that you put up, the best we can do is assess all of the four people
Things
together.
together. Yeah. No, soon after that, I cross-checked with Varizome for the penetrance, but I don't get any much data. And I have asked she's she's our senior. I asked her for her help. We both discussed and we have searched for a couple of websites too, but we don't have any clinical evidence for that. It is a penetrance variant. So that's why I'm not sure about the penetrance of that particular US variant. Yeah. Anything to say or any discussions to make me aware and make me hi Myres sir, good evening. I think you're there.
Hey, hi, Krishna. Amazing presentation. The case study was really interesting.
Thank you, sir. Thank you. Sir, I need
I
inputs from you because we are at
I have a I have a question. So, for SCN family of genes, so once you got the AD variant and you could see father is asymptomatic, did you get any positive family history of seizures or some
no sir.
neurodevelopmental disorder
No
on
sir.
the side?
Nothing. Because I actually want to include the pedigree too, but
Mhm.
unfortunately I'm running out of time. But there is no a pedigree, but no family history. I mean, I lost the paper there. No family history, sir. Completely no family history, and the I mean. The parent has two siblings, two sisters,
Mhm.
both having children. Everybody are normal, and they were going to school, and everything was good. And when to the maternal, they both mother and father was they are at 50s without diabetics, hypertension, and yeah, that is what a good family history without any complications. That's what we found.
Okay.
Yeah. And Dr. Aruna also, she also helping us to cope up with the case, but we are left with a lot of question marks on where to move and what to say to the parent, because he is very anxious. As we know, the condition is like that, and the gynecologist and radiologist has been quietly escaped. I can't say the word escape, but they can saying, because it's a malnutrition case. Even radiologist and I can't able to say anything. That is what you can't able to question me. Whenever the parent questioned, so you said situs inverse is nothing to do anything, because the baby can be good fit and everything was good, but the conditions was not quite as you said. But the gynecologist replied, you can't able to blame me because it's a malnutrition case. So that's what quite out of the box to me too. and the radiologist who given normal report in TIFA, but the baby was slightly, facial dysmorphism and microgatia, and that actually raised the question of the rural areas of scanning centers. It also one of the questions that usually focused on.
So I think I lost it, but was the so the she's currently so she delivered the baby girl, right? The second child.
Second child.
And was the child tested for genetic conditions or for the variant?
Not yet. I mean, we asked it now because the complications has been much more complicated, and we just pulled off that, and we asked it for them to couple carrier screening, and we also advised for whole exome sequencing for the baby too, and then we are getting data from the previous child whole exome data.
Okay.
I think just 1 week has been happened. We have sent to the testing. The results yet to come. But I just want to present, since it should be in unique case, and even seniors like Dr. Arna can't, we don't have any particular put on a note to explain it thoroughly. So I just want to present and get inputs from you people too. That's what I presented the case.
This case kind of reminds me of a very like a trio thingy can be done for the father and like the two affected children. But then again, if some other VOS comes in the other child, it will be completely different ball game. So
Yes.
it will majorly depend on what does the literature say like on this thing. Are there reported cases where there is an unaffected parent and unaffected child or something like that?
No, we have searched for a couple of literatures, but those literatures are, are for a different gene. But SCN3 was quite different, but it doesn't have any, physical abnormalities, kind of, facial dysmorphism and that that asphyxia, brachycardia, and those are things are not essentially mentioned. But don't know. Something has been tricky in this case to figure it out. Yeah.
So you said the first child, did it have any like facial dysmorphism?
Yes, yes.
Okay.
Like,
And they did
like
do a microarray?
no,
Okay.
no further tested. They just directly soon after the clinician advised for the whole exome sequencing. The test was advised by the clinician himself.
Okay.
So then they turned to the particular variant, and the whole drama has been started. Yeah.
Because there are a lot of open ends which I see like as a genetic counselor. It could be like one of those cases where the genetic testing goes to an extent where you're like, okay, where do we stop? But then there are a lot of indications that might be like,
And I was seen, I'm not mean intended to say this, but I just want to ask that particular counselor how to counsel the patient, but I didn't do that because it's not my job to poke that. But I've seen the summary and I've asked the parent how they counseled and how the situation happened. The counsel is completely segregated to that, but your baby has been got that variant because of you. Yes, that's a particular point, but it's not the way that they can set to that. That leads to completely different scenario to the family, and it went to the negative impact on the whole scenarios. The wife was blamed, yeah, because of you. Our child got, because we didn't know, because it's a VUS variant. We don't know whether this particular condition is happened because of that variant or not. We don't have still evidence, but the counselor has been counseled in that way. So it's a different scenario. Yeah. So that's why,
no,
that's what I mentioned. Whenever we are counseling the patient, we must aware of how to counsel the patient, how to give the case. I mean, how to present the scenario, how to make it neutralized way, because it's an Indian, it's a different cultural entity where we are, as I mentioned, blaming on each other, and it ultimately leads to divorce. So a single counseling session can make chaos in the entire situation. So that's why we need a psychological understanding, and we have to be shoes in their parental mode of their placements, and then we have to counsel the case. So I hope this case would make a little enough add on to your perspectives. That's why. So I'll definitely get back to you people soon after the case was concluded, and if any report has been come along with, I'll definitely share with you.
Is there any possibility of a CMA being done in this case? Because from a very general overview of the SCN3A neurodevelopmental disorders, there's
Mhm.
also a genetically related allelic disorder which also includes micronathia along with already the conditions that are associated with SCN3A.
Okay,
So,
okay.
Yes.
is there a possibility that a CMA can also be done?
Okay, let me check.
Maybe it's
Yeah.
Sukriti and Dr. Krishna, I'm so sorry to interrupt.
No,
If
no,
I
please.
may, I would suggest that you do an exome depth like a pipeline. I'm sure third party companies have this pipeline. So, what you can do, you're already doing an exome analysis. From the exome, there are pipelines which can give you the CNV data through exome
Okay,
depth or CN mops.
okay,
That will give you smaller deletions like less than 50 base pairs are caught by the exome itself, but
okay.
more than that are caught by these pipelines.
Mhm.
So that can be done for the first and the second child both if exome is being done.
Okay, okay. Actually, I've seen the previous child report. It's about 100x depth. They were very clear on it. The depth was good, and I asked it the thing, and they are ready to send the VCF data too. But okay, I'll definitely let our diagnostic team to cross check it with them. Thank you.
It'll be really good if you have the VCF file and you can check for yourself, and you can also check the score of the variant that is there, like on other. I'm not sure what sort of variant it was, but SCN3 shows, as Sukriti mentioned, variable penetrance, but also, and I would encourage you to publish this case if the family consents, because there
Yes,
are only 3 families in the world which have been reported, like
yes,
just from
yes.
a rough literature survey.
Soon after
So
that, I've counseled the patient in a way, actually. In a way, I've cross-checked with the literature. I got nothing much, and even with the penetrance, I got nothing to express. So I counseled the patient of rare disorders initially. What are the rare disorders? Sorry, got some lot of disturbance. Okay.
Yeah,
So
even I
now,
agree with Sukriti and Khyati. That's was the reason why I said microarray, because it is showing SCN3 and gene families have often like the variant might come up, but you might also find something on a microarray which might be significant. And
okay.
like you said about, it's very unfortunate how the counseling happened, wherein the SCN3 was given importance and the blame game started because it's not relevant right now.
Yes,
And the
I just counsel the patient from him, in the perspective of, sir, please forget the gene because you are asymptomatic. Then your child might also be. So that is not the point. See, we can't say this particular gene is responsible. We just asking the patient. I mean, we just asking that don't focus on that particular gene or particular variant which actually present, because you are not responsible for the conditions. Because if the same gene which has been present in your baby, then he might also be an asymptomatic. That is what the actual phenomena has been going on. For example, if we have seen the same of random variant of a autosomal dominant characteristics if a parent is not parent is asymptomatic for a dominant condition, we don't know that a random test has been made for the baby, for the first baby. We got a report of the baby with the same variant of autosomal dominant condition, whether you can say we have to terminate the baby or not. That is what my question is. Because the parent is asymptomatic, we don't know any child or any, it's a first child. They randomly got sequenced of her baby. We got to know the same situation here. Whether we are going to say terminate the baby or we have to go say, I mean, so what's your thoughts?
I would leave it to them. But I would explain everything, the pros and cons, and like how you mentioned in detail that we don't know. It's we are on the fence, so then
Yeah.
they can take a decision. you'll have to tell them about the life that there will be if the child has some problem, and if the child does not have an issue, then they can like really imagine, and probably that's how I would
Yeah.
counsel.
That's a tricky question, and we can't able to, we can't able to conclude it to the one end because it's completely, we don't have a literature initially. That's what the biggest problem is. But as to this situation too, and even though the parent is very anxious and very prepared with NIPT and microdeletions and with antenatal scans and everything was quite good, but even though the baby was second child, there was also with the problems that actually improved psychological distress of both parents and lead to divorce and for the mental trauma too. That's why its counseling is very important. That is what I can conclude with the session. Counseling was very important. Whenever you are going to the counseling session, you must be checked twice to how to counsel the patient. It's not about what you are counseling, it's how to counsel the patient. We have to be a good perspective and a balanced perspective because as we are in India, we have a lot of societal dilemmas and changes. That is what I want to say.
Dr. Krishna, I have one more question.
Yes, yes.
So the wife has been accompanying him for all these sessions for counseling.
Actually, they both have attended the first counseling session what they have done with the previous genetic department. So not for the whole exome sequencing, but then she, then for the second counseling session she is not there. I counseled to the parent, the father. Then for the third counseling session she was there. Even I counseled. Dr. Arna was there, counseled, and yes, but ultimately it's their decision. We can't able to say.
Yeah. They seem to be in a difficult
Yes.
situation, and we also seem to be in a difficult situation.
See, once they got to know that the parent has a dominant variant and the same variant present in the parent, and the parent is responsible for to share this particular variant in the child, bas kuch bhi nahi. They said to their family, and their family said to them, they just don't know about variant or anything. They're saying father is responsible for the child's condition. That actually drama has been started. Yeah, we can't able to say as being, we are getting the case, we are open up and we try to conclude it. We'll see. Soon after the data, I'll definitely share with you.
My dear, would you like to speak?
Yeah, this is very this is very interesting case from a counseling perspective. So also like to tag along with like Kathy's question, uh, what was the understanding like of mother for this VUS? Because there's like a direct blame game happening, and like it was a VUS. So were they like in a notion where they had understood the VUS and what it means, or
Yes,
they were
Sana,
like,
she understood actually. She understood the condition, and we have said that. And for the second session, what we have done with both the couples for the couple carrier screening, we asked it, we showed some couple of images and some couple of cases that already has been done, and this particular VUS variant. That's why I mentioned if the same VUS is really crucial and really essential and really poked that and pointed that the parent is responsible, then why can't we check it for the second baby? That is what I asked the partner, the mother, because we found that the VUS variant is just nothing. That's why I'm not saying nothing.
So I'm
That's
sorry
not.
to interrupt. I'm just conscious about the time this call might end. We can rejoin again. Yeah, just letting you know. I am extremely sorry. It was just a 1 hour timing. I don't know. Google Meet has also started this.
No, I
Thank you.
Are you ready to call on this, or this is just discussion now?
No, I am getting this as well.
Yeah. Yeah, that's it actually. But I focus that I counsel the mother in a perspective of that particular VUS variant, we don't have any clinical evidence, we don't have any data. Essentially, that's what we neglect. I mentioned the word as neglect because if it is such admirable and it is such dedicated to that indicated is that particular variant is responsible from the father, then why can't we check that particular variant in your baby? That's what I questioned the mother. But even though she, the first impression is the best impression, she has the best impression on that. But okay, counseled. But anyhow, we'll see how the actual strategy. But the thing is, as Mayuresh said, if anything in future we got a random VUS variant in the child second pregnancy, that would be, I mean, second child, that would be much more chaos than anything, because we can't able to justify in both cases. But we'll see. Yep.
If I may add, I do not have much knowledge about the clinical aspect of this, but I think this case is both teaching heavy as well as like counseling heavy, because there's a lot of relationship dynamics that comes along in this case, and while counseling, we have to make sure that we are addressing or maybe making sure that we don't open up more gates into this case. Um, but I just wanted to know, sir, usually such tests do have consent forms, and they also mention about incidental finding. So was this a consent given for US by the parents?
No, I'm not sure because, yeah, as you mentioned, for the particular incidental, of course, how can it would be an incidental finding?
Mm,
It is not an incidental finding, no. We are cross checking for the same symptoms, and we got a variant which is similar to the clinical indications. Then definitely it's not a incidental finding. As you mentioned, for such incidental, if we are doing whole exome sequencing for this particular situation, but the mother got BRCA positive, then it's an incidental finding.
Yeah. For me, asking this question was in term of for the newborn baby, the girl child. Because,
Hmm.
in order if in a way, if you're getting her tested and you're conscious about the fact that you don't want any other incidental findings to be come into the picture while making sure this case doesn't open up more gate, maybe a consent could be signed off for.
No, actually, we must. To my perspective and to my knowledge, we are not. We are not in a position to check only that particular US variant in this child. No, we are very fresh to this case too, because she also have ileotomy surgery. It's a major surgery, and situs inverse. It's autosomal recessive condition. So that is why both the parents should be screened, couple career screening. That's why we asked for essentially, because both the child, and there is no miscarriage and no any, they are not a smoker, or he doesn't have any habitual, any, there is nothing. They are educated and everything. That's what the situation was very tough. And but as I mentioned, both children's case were fresh and both the indications were fresh. That's why we have to go with what are the indications that have been provided in whole exome sequencing. We have to give. So there is no point of incidental finding or anything else in the baby. As I mentioned, incidental finding is something like if they are get any BRCA positive, then it is the incidental finding. Or so
Mm.
as such, to my knowledge, if anyone add up or something, you can. Yeah.
Yeah, no, I agree with the incidental finding thing. So, incidental findings would, like you said, include something that is found outside of the phenotype that is given. Like we found it just by chance, or a variant, for example, in the HBB gene or the BRCA gene, like Dr. Krishna said. So the variants that we know are founder variants, or we know that are definitely causative. So those are the ones that we would report for incidental findings.
Yeah. Yeah.
Is there any other question that needs to be addressed?
I don't have any more questions.
I don't have any more questions, but I really applaud your presentation, Dr. Krishna. And it was really interesting because I'm sure these situations arise a lot. We recently saw a family where the woman wanted to separate from her husband because he tested positive for a heritable cancer gene. So,
Mhm.
and he's quite young as well. So this was an interesting topic to pick, definitely. And I really hope that you get the VCF file, and I'm interested to know what you find in the first child after reanalysis.
Definitely, definitely.
And also the exome depth pipeline, if you could work that for the
Mhm.
first child, it would
Yes,
be
I've written here. Definitely, I'll like, mention to the diagnostic team and NGS team who are working on it.
yes.
Thank you.
Wishing you the very best. Thank you.
Thank you. Thank you.
Yes, definitely do update us once you get the analysis done.
Definitely, I'll do. I'll do. Because it's in between now. I just raised up a question and discussion open to that. Uh, the only thing, I just want to present this case, even though it's in between, because of the scenarios has been turned up and the counseling session made everything chaos, to my knowledge. So that is why I mentioned. So whenever we are counseling, we must be very, responsible to do the counseling. Yeah. It's just not a counseling session. It's definitely a life-changing one. That is what I can say. And thank you for the opportunity, especially my Vaishana and Shraddha, and thank you for asking. Thank you so much.
It's a pleasure, sir. Thank you for sharing this information because you rightly mentioned that one counseling session can actually change a lot in a family relation and dynamic, and we counselors have to be quite aware of that fact.
Yeah,
Yeah. We would very much like to schedule a meet again and talk about the outcomes that you have come across the case after a duration of time.
definitely, definitely.
Thank you so much, sir, for joining in today.
Thank you so much. Yeah,
Thank you.
we'll wind up. Yeah, bye.
Yep.
Bye.
Have a lovely evening. Thank you.